Are you considering going into a house calls practice? In the last decade, there has been a resurgence of home-based primary care, more informally known as house calls. This is a brief introduction into home-based primary care brought to you by the Gerontological Advanced Practice Nurses Association, or GAPNA. Providing primary care in the home is a need in every community. Nationally, there are over 1 million people who meet the definition of homebound. Most are frail, older adults. This is an untapped potential in healthcare. Without house calls, a patient's only access to healthcare may be through the emergency department or hospitalization. Thus, providing consistent and appropriate access to care for patients with chronic illnesses can reduce unnecessary emergency room visits and admissions. Older adults with multiple chronic conditions, including those that are homebound, account for 43% of Medicare admissions. Multiple chronic conditions are associated with loneliness, increased risk of hospitalization, and worsening health status. House calls are proposed by the Agency for Healthcare Research and Quality as a way to provide care and address the needs of the homebound. And yet, less than 12% of individuals who identify as homebound receive home-based primary care services. While there's an obvious need in all communities, these services are often either not available or their existence is unknown to the population in need. Sooner or later, everything that is old is new again. While house calls may be new to you or your patients, there is a long history of patient care in the home. Most medical care was house calls before World War II. However, in the 1930s, house calls dropped to 40%. Mainly due, then, to the development of technology, a focus in clinic and hospital settings. Furthermore, practitioners started specializing in specialties such as internal medicine, surgery, and others. The public back then began to equate good healthcare with hospitals and clinics. In the 1950s, the house calls practice went down to 10% and then to less than 1% in the 1980s. However, to this day, house calls are still very common in Europe, Canada, and around the world. Many non-healthcare companies are moving services away from brick-and-mortar offices, a concept the public is becoming more familiar with. Therefore, the misconception that good healthcare only occurs in hospitals is changing. There are 3 types of home healthcare, each with varying degrees of involvement, such as time, professional training required, and so forth. Home-based primary care, or house calls, are medical visits performed by healthcare professionals who deliver medical care. Skilled home health, on the other hand, are nursing visits by home health nurses as well as social workers, physical therapists, occupational therapists, speech-language pathologists, and others. Custodial care is provided by informal caregivers that may include family members, significant others, as well as privately hired caregivers to assist with activities of daily living. There is a spectrum of home-based care, from the lower acuity chronic care, which includes little or no provider involvement, all the way to high acuity care with a high level of provider involvement. Informal services are those that may be provided by family members and friends. Formal personal care services may be provided by caregivers with or without formal training or licensure. Skilled home care is provided by licensed healthcare professionals such as registered nurses and licensed vocational or practical nurses. Home-based primary care is provided by medical professionals such as doctors, nurse practitioners, and physician's assistants. Hospital at home is a new concept which allows for delivering home care with a high acuity level of care comparable to that of a hospital. What qualifies a patient for house calls? A patient does not have to be a Medicare-defined homebound patient, but will need to have a documented medical necessity for home visits. There are various conditions that qualify a patient for house calls. Cognitive deficits. Providers can become an advocate and an educator for these patients and their families. Functional deficits. A house calls provider can bridge the gap if the patient cannot get to a clinic. Need for in-home assessment. House calls providers can be the eyes and ears to further augment a patient's care plan. Medication review, the reduction of polypharmacy, and the medication appropriateness are an integral part of the house calls visit. High risk for readmission. With the built-in intimacy of a house calls visit in a person's home, a provider can identify risks in a patient's day-to-day life, or in some cases, if transportation's limitations compound the chronic comorbidities. There has been recent trends influencing the resurgence of house calls. Increased life expectancy has resulted in higher rates of chronic illnesses. The emergence of team-based approach to medicine and nursing care comprising of doctors, nurses, social workers, and others. Value-based care has a promising savings of healthcare spending and includes home-based primary care as one of the ways to reach this goal. Medicare has likewise added billing codes with increased reimbursement for house calls, including assisted living facility visits. Technology advancement has propelled the house calls practice back into a resurgence because of how technology has made delivering medical care to the homes more realistic and streamlined. Nurse practitioners have increasingly had a prominent role in home-based primary care. Nurse practitioners have provided access to care for the vulnerable, homebound older adult population and have provided the highest growth in house calls over the last decade. In summary, why do house calls? House calls have the potential for a substantial decrease in emergency room visits and hospitalizations, decrease in hospital or long-term care stay, and the overall improvement in patient satisfaction and patient quality of life. These are just to name a few.